The Scottish Trophy. Muscular Dystrophy. Welcome to another sketch. Let's warm up those muscles by talking about, you guessed it, muscles. We'll discuss muscular dystrophy, a spectrum of inherited progressive myopathic conditions. For this sketch, we'll focus on Duchenne muscular dystrophy and Becker muscular dystrophy. Since these jagged rocks first pushed their way out of the cold Atlas Sea, the Scots have come together from across our land to challenge each other in tests of strength and skill. The Highland Games separate the weak from the Scottish, but in the end, only one will earn the right to raise the Scottish Trophy. Duchenne muscular dystrophy, or DMD, represented by this weak kid from the Duchenne clan, is probably the most familiar and certainly the most common type of muscular dystrophy. Muscle weakness secondary to muscle fiber degeneration is the key characteristic, and this degeneration occurs in skeletal and cardiac muscle. Duchenne, poor lad has a big heart, but it's a weak one, just like his skinny little arms. He'll never win, but he'll never give up either. As with Becker muscular dystrophy, the disease-causing mutation in DMD affects a protein called dystrophin within the muscles. Duchenne has more severe symptoms, and these patients generally have less than 5% of the normal quantity of dystrophin. Becker muscular dystrophy, on the other hand, represented by the stronger kid from the McBecker clan, is a later onset, mild form of disease due to less significantly reduced or dysfunctional dystrophin. Remember, all of this is a spectrum from mild to severe, giving rise to intermediate cases as well. Now, that McBecker lad is trouble. He thinks he's tough because he can push around little Duchenne, but he's far from the strongest Scot around. For the rest of the script, we'll focus on Duchenne, but we'll compare and contrast with Becker as we go along. And remember, the Duchenne family has a lavender tartan, while Clan McBecker wears only red. Please remove your caps and put down your whiskey as we honor the flag of our great land. Duchenne muscular dystrophy is inherited as an X-linked recessive condition, which means it occurs almost exclusively in males, and the same goes for Becker as well. That said, females may be symptomatic carriers. Just under 1/4 of females with a mutated gene will have clinical symptoms, although there is a wide range of severity and age of onset. She's also wearing the McBecker tartan to reflect these reduced symptoms. An ordinary Scottish lass of 5 would be able to carry at least a mid-sized boulder with no difficulty. For affected males, the onset of symptoms usually happens as a toddler, with the weakness becoming evident around 2 to 3 years old. This is commonly seen as late gross motor milestones, like delayed walking, difficulty walking and running, and trouble climbing stairs. Or in other words, all the things you need to do to win the Highland Games. Note that for Becker dystrophy, patients tend to present a little later, around 5 years old, though this is also much more variable than Duchenne. BMD patients can present as late as 60. This delayed or difficulty walking is often the first sign that brings parents in. Just because kids are a little behind doesn't mean they have muscular dystrophy, but it should be on your differential for these delayed milestones. Parents may note general weakness, usually in the legs before the arms, and patients may be able to localize pain to the legs, especially early in the disease course. Come on, boyo! He's the Seamus, boys. He'll have trouble getting over that wall and not on the other side for his effort. Finally, some boys may have the strength to walk, but are seen as clumsy given their consistent falling from weakness. Aye, but some lads are just clumsy. When I was a wee bairn, I walked about like I had a dram too many. Time to move on. Let's talk history. Surely, the Kingdom of Scotland was founded in the 9th century by a union of the Picts and the Gaels. Not that history. The history of present illness. Well, why didn't you say so? The classic thing that parents may have noticed is Gower sign, which is when kids walk or climb their hands up their legs to push themselves into standing position. Of course, they won't say Gower sign, but you'll know what they mean. Gower the Unsteady was the first chief of the Duchenne clan. How's that for some history, eh? Parents may also mention other signs, like toe walking, that are characteristic of DMD. We'll talk more about these when we get to the exam. In addition to the HPI, a complete family history is essential so that you can look for the X-linked recessive pattern. Enough talk. Time for action. When you think about it, the Highland Games is really just one big physical exam. When you're ready for the physical exam, focus on the pattern of weakness. Expect symmetric proximal weakness, usually affecting the lower extremities first. The calf enlargement classically found in DMD is actually pseudo-hypertrophy, a process of degenerated muscle cells being replaced by fat and fibrosis. The quadriceps can also be involved. These pseudo-hypertrophied muscles feel firmer and rubbery on exam. There's a smart lad. These games can get a wee bit mucky, and proper footwear is critical to achieve victory. As the disease progresses, muscle wasting and contractures are seen, and these patients may also have hyporeflexia or even areflexia on exam. Ah, little Ben, where do you think you're going with that wee small X? Ask the patient to stand up from a seated position on the floor. The Gower sign will be evident when the patient must use hand support to push themselves to a standing position, given the weakness in the proximal legs and pelvis. As the pelvic girdle weakens, patients start to have a waddling gait, and lumbar lordosis can also be seen. Hey there, you little dishamus punk. I do not ken what you're doing, but don't mess with me, duck. You won't get away with this, you great bobber. The contractures we talked about before can also lead to the characteristic tiptoe walk, as the Achilles tendon develops contractures. We'll talk more about the cardiac effects of DMD when we get to the complications, but this disease can cause dilated cardiomyopathy and conduction abnormalities, so make sure to do a cardiac exam, especially on older kids, since the cardiomyopathy becomes increasingly common in the teenage years. What labs will be helpful in your diagnosis of muscular dystrophy? First up, CK, or creatine kinase. The CK level is elevated before symptoms present, and can be already elevated in infancy. At its peak, early in the disease course, the level can be 10 to 20 times normal, before slowly decreasing. This elevated CK is seen in both Duchenne and Becker, which is why our chicken-eating friend is wearing the McBecker tartan. Ugh, did you just call him a chicken eater? My God, man, have some common decency. Some patients may actually be initially discovered after an incidental finding of elevated transaminases, that is AST or ALT. Chicken eater or nay, that's man with the right idea. A barrel of whiskey and a flagon of mead will send you on the path to great success. Cheers to you, chicken eater. Now we come to the crux of the matter: dystrophin gene testing. Anytime you have a suspicion of muscular dystrophy and an elevated CK, your next step is genetic testing, which is how the diagnosis is most often made nowadays. The majority of cases are deletions of one or more exons, so start with deletion and duplication testing. If negative, you may need to go to genomic sequencing. If genetic testing shows no disease-causing mutation and your suspicion is still high, you'll need a muscle biopsy. This used to be the key to diagnosis, but it's rarely needed anymore. That said, you may still be asked about the findings, so remember that you'll see muscle degeneration and regeneration, and significant replacement of muscle by fat and connective tissue. Watch where you poke your little stick, McBecker. You'll put someone's eye out if you're not careful. It turns out that Duchenne and Becker aren't the only muscular dystrophies around. You'll want to think about the others when forming your differential, especially since they can present very similarly. Make sure to take a good history and do a careful exam, and remember that genetic testing may be able to help you out in a pinch. See our differential diagnosis menu for more. Thanks to your excellent clinical skills and unparalleled ability to read reports from the lab, we've got a diagnosis. But as William Wallace once said, a diagnosis is only half the battle, and he was a man that knew a thing or two about battles. Duchenne muscular dystrophy is a chronic disease, and these patients will need active therapy their entire lives. As such, it is important to get the right team on board. Consult a neuromuscular specialist and geneticist or genetic counselor at the beginning, and don't forget about maternal counseling for future pregnancies and carrier screening for family members. Finally, someone to organize this great massive buffoonery. You'll also want to start your cardiac monitoring with an ECG and echo. These will be continued annually, though you may switch to cardiac MRI as the patient ages and develops scoliosis. In fact, it's probably not a bad idea to get a cardiologist on board as well. And by not a bad idea, I mean that's what the guidelines suggest.
That young lass with the booming voice is a electromyocardiogram. The myocardiogram carton is so distinctive, you'll never forget her. But enough about that. It looks like the moon put is starting. This is one of my favourite events.
One of the mainstays of pharmaceutical therapy for these patients is steroids, specifically prednisone or deflazacort. The mechanism is unclear, but steroids provide many advantages, including improved muscle strength and delayed physical deficits. Patients typically start steroids around 4 years old and continue them indefinitely. Note that while this is definitely indicated for DMD patients, the benefit in BMD is less clear. Due to their cardioprotective effects, ACE inhibitors or angiotensin receptor blockers should be started in all DMD patients at age 10.
That there is Abernathy. He's not actually a guard, just likes a wee bit of cosplay on the weekends. Hello, Abernathy.
A strong rehabilitative program should also be put in place at the time of diagnosis. Even though that Duchenne kid looks uncomfortable, physical therapy is indicated to encourage mobility, decrease risk of contractures, improve pulmonary and cardiac outcomes, and focus on pain relief. These patients and their families will also require psychosocial care with routine mental health assessments. What about treating the disease itself rather than just its symptoms?
Now there's an idea.
There are some novel disease-modifying pharmaceuticals that aim to increase production of functional dystrophin. Unfortunately, the true clinical benefit is not yet known, but trials continue. These new drugs include eteplirsen and ataluren, but data has only shown benefit in about 10 to 15% of cases.
Well, it's certainly not perfect, but as my grandpa Rufus used to say, something is better than nothing. But then he'd yell, "Hold your waist, you little dauber," and finish his bottle of whiskey. A complicated man he was, but full of wisdom.
Anywho, other investigational therapies are in the pipeline as well. I know we say this all the time, but remember to vaccinate these patients, including the annual flu shot. You will also need to plan for live virus vaccinations before starting glucocorticoids due to their immunosuppressive effects. Let's talk about complications, which are unfortunately pretty extensive in DMD. Or really, we should probably say sequelae, since many of them are considered a natural progression of the disease rather than individual complications that can be avoided. As we mentioned before, one major concern is cardiomyopathy, characterized by myocardial fibrosis, left ventricular enlargement, and/or left ventricular dysfunction. While we're on the subject of dilation, let's mention this other condition known as Duchenne muscular dystrophy-associated dilated cardiomyopathy, a form of cardiac involvement without the skeletal muscle involvement. I only say it so you've heard of it. And that's all I'll say about this particular entity. Don't say I never did anything for you.
Wait just a wee minute here. There's nice sack race in the Island Games. What are you doing, you rubbish children?
In addition, the risk of conduction abnormalities leading to arrhythmias increases with disease progression.
Another one! Poor lad is shaking like a wee baby lamb. But where are they coming from?
Together, these can lead to full-on heart failure, which usually becomes symptomatic in the teen years, so remember that annual cardiac monitoring. Cardiac involvement in Becker muscular dystrophy may be appreciated earlier on, sometimes even as the predominant presenting symptom. The theory is that because these patients can exercise, given their mild skeletal muscle weakness, cardiac myocytes with abnormal dystrophin may be worse off because of the mechanical stress. A progressive scoliosis also develops in nearly all cases, which, when combined with a progressive weakness, can lead to impaired pulmonary function. Respiratory infections and even acute respiratory failure can occur. These infections need to be treated aggressively. Vital capacity should be monitored regularly, and in most cases, nighttime ventilation and eventually daytime ventilation will be required.
There's no sound in the world quite like the tuning of the lung pipes. Bring a tear to me eye, and a joy to me heart.
These patients also have an increased rate of cognitive and behavioral issues, such as intellectual disability and learning disorders, as well as anxiety and depression, ADHD, and OCD. Treatment of these conditions is the same as for any kid. Also, make sure you consider the side effects of treating DMD with chronic steroids. Most commonly, you'll see weight gain, hirsutism, and a Cushingoid appearance in these patients. But be on the lookout for impaired linear growth and delayed puberty as well. And as always, with patients on chronic steroids, don't forget the possibility of adrenal insufficiency with any abrupt discontinuation. Patients and families should be taught the warning signs to watch for.
That hat's not doing too much for you, laddie. Best to shut your put and get yourself down to the sheep farm to knit a new one. Mind you're careful with the shearing now.
Due to osteopenia of immobility and daily steroid use, pathologic fractures become a major concern, so pay attention to bone health.
And sock health. Where are your shoes, you wee bampot?
With all of these complications, certain procedures and surgery may be required, but keep in mind that these patients are at a higher risk of having problems after sedation or anesthesia. Issues like rhabdo, airway obstruction, and difficulty weaning the vent mean that thorough pre-op evaluation and close monitoring post-op are essential.
Ah, yes, the risky in. I dinna recommend it.
Sadly, despite improvements in therapy, the prognosis for patients with DMD remains poor. While there may be short-lived improvement between 3 and 6 years old for some patients, it is invariably followed by a persistent deterioration.
Remember, that feels never what the Americans call football, a slow and dull form of torture. It's for Scotch rugby, the king of sports, and a staple of the Highland Games.
Patients will usually lose the ability to walk by 12 or 13, becoming wheelchair-bound. This is followed by rapidly progressive scoliosis and contractures.
How does Scotch rugby differ from regular rugby? Thanks for asking.
There is still a shortened life expectancy with Duchenne muscular dystrophy, but survival into adulthood is now possible. Many patients live into their 30s.
In Scotch rugby, you drink Scotch every time you score. Pretty simple, really, though after a while, there's not much scoring anymore.
Prognosis for Becker patients is better than for Duchenne patients. BMD patients usually retain their ambulation to at least 16 years old, if not into adulthood. And long-term survival is better too, though it's still not great. Most Becker patients survive into adulthood with a mean age of death in the mid-40s. Given all of this, advanced planning and palliative care should be used throughout the disease course to help patients and their families. And on a more positive note, given improved therapies, survival, neuromuscular function, and quality of life are improving.
Oh, thank God for that. It was starting to feel a wee bit bleak. Oh, I know what you're thinking, but before we head to the pub for a dram, why don't we take a quick look at the medal table and see what happened at the games today?
Duchenne muscular dystrophy, or DMD, is the most common type of muscular dystrophy. Becker muscular dystrophy, or BMD, is a similar but milder form of the disease with later onset. DMD results from a mutation in the dystrophin gene that causes degeneration of skeletal and cardiac muscle. It is an X-linked recessive condition, so it occurs in males. The weakness of DMD first appears around 2 or 3 years old, while in BMD it can be much later and much more variable. Delayed walking is often the first sign of the disease. Parents may also mention that their kid has to use his hands to push himself upright, which is called Gower's sign. On exam, look for calf pseudohypertrophy, hypo or areflexia, and gait changes like waddling gait or toe walking. Definitely check a CK when ordering labs. It will be significantly elevated early in the disease course before slowly decreasing. And get a dystrophin gene testing as well, which usually will make the diagnosis. At the time of diagnosis, get a cardiac workup, and then continue to get an ECG and echo annually. Glucocorticoids are the mainstay of treatment for DMD, and are usually started around 4 years old. You'll also want to start an ACE or an ARB for cardioprotection, usually around age 10. PT is another important part of treatment, and can help maintain mobility and reduce pain. Dilated cardiomyopathy is a serious complication of DMD and can lead to heart failure. Cardiac disease is especially important in Becker muscular dystrophy, where it can be the first presenting symptom. Most DMD patients develop scoliosis, which can cause impaired pulmonary function. And don't forget about steroid side effects, since those can cause their own problems. Unfortunately, life expectancy is significantly shortened in both diseases. DMD patients usually do not live beyond 30, while BMD patients typically live until their mid-40s.
All right, I know that was a little bit peely-willy, but take a deep breath and we'll be getting you on the same mega. Yeah? Oh, then me as a will tripa. I'll take a caravan and... Oh, where is me pint? Oh, there's me pint.